Hey, what up all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. We are continuing our RPD Removal Partial Denture series with components. We are going to be talking about major and minor connectors. Today, normally in the series, we'll be talking about various different components, and they are lengthy components, right? So there's going to be an introduction which has been covered. Today we're going to be talking about major and minor connectors. Of course, the following lectures will have other table of contents such as rest and rest seats as a separate lecture, direct retainers, clasp assemblies, then comes in direct retention, denture base, and of course we'll consider implants, and that will conclude our entire RPD series one after another. But like we mentioned today, let's just talk about major and minor connectors. So this, as usual, let's just talk about the components of RPD, right? This is a very complicated diagram. However, if we look at it one thing at a time, we will be able to notice various different things. Let's take a look. So for example, what's A, right? In this case, A. So let's spot A, which is right here, and that belongs to a major connector, right? So major connector, what you can see here is very rigid, it's metallic, and it controls left to the right. It connects the left to the right. It connects these little components that kind of go up. It gives the entire denture base support. So this is what it kind of looks like, right? If we're looking at essentially the A section here, look how thick and bulbous this metal is. Not all major connectors are like that, by the way, but they give rise to B. And what is B? Rests. Then there's retainers, which are direct. Then there's, of course, the minor connectors. So major connectors have a component called D, which allows any other component of tooth structure, of acrylic, anything from major connector to a very specific functional component, such as a clasp, direct retainer, to connect, right? So for example, major connector has, and of course I'll erase this for our knowledge here, the A, which is a major connector, gives rise to another vertical component, and keep that in mind, vertical, right? We're going to use that again later on, vertical component. That connects the major connector vertically to the rest. Okay, so that's the function we're going to talk about today of the whole RPD, and this is of course the upper. That was the lower, this is the upper. And of course this is a type of various different types of major connectors. Okay, let's dive deeper. First of all, let's define it. What is a major connector? A major connector is defined as a component that connects components of the partial denture on one side of the arch to the opposite side. Fair and simple. Connects this side to this side. Very simple. It serves as the foundation to which all other parts are attached, and that includes minor connectors, right? It provides a cross-arch stability, and this, again, this not only could be an exam question, but it's also a very, very foundational concept. Major connector is a cross-arch stability component. It resists displacement of the denture from functional stresses. So why does it need to be rigid? Well, imagine a flexible major connector can cause damage to the periodontal support. Imagine if this component right here or this component right here was flexible. Could you imagine how much pressure it would put on the tissues that it touches? Well, it leads to injuries on residual ridges. And we can't have that because that will retain the denture eventually. And then, of course, if there's residual ridge losses, it will lose the retention on denture basis. It results in tissue impingement if it is flexible. And a dentist must ensure a proper design and fabrication, which includes its rigidity. Okay, moving on. Location guidelines. A major connector can't just be placed anywhere. There has to be a guideline that we must follow. And the guidelines are, it must avoid movable tissue, number one, right? It avoids movable tissue, which means, for example, if the tissue is such as a corner of the mouth, which is movable, the labial mucosa that is movable, a major connector that is a rigid metal will not be able to stay there. It should be placed on firm structures such as the rugae, the palate, for example. The alveolar mucosa, which is keratinized and rigid. There should be no impingement on the gingival tissues, and that kind of links to the first point, right? It must be at a safe distance from gingival, which is highly vascular, highly reactive tissue, and it supports the teeth, of course. It avoids the prominent bony and soft tissue areas. Now imagine, for example, you are a patient that has a very, very bulbous torus. Could you imagine putting a tight, rigid metal band over the torus? How uncomfortable would it be? So if you had a major connector that builds around that torus, all of a sudden that becomes very comfortable. We gave relief to the prominent bony and soft tissue areas for smooth placement and removal. Then, of course, relief is the next point. It prevents the settling into the tori, median palatal sutures. So imagine there is an area here, right? So this is the incisive foramen. So over there, that's in the bone itself, that's where the nerves come out of, the incisive nerves. And then, of course, there is a mid-palatine suture region that follows posteriorly. This is a very sensitive area. Therefore, we need to relieve it. We can't have a tight metal component fitting this area. It has to be relieved. And apologies for this impingement of the sentence. An impingement is something we cannot have. Yes, the joke is intended, guys. We must prevent tissue impingement, especially in the distal extension dentures. There are some dentures that are distally extended. What that terminology means is, imagine if this is the denture we're going to make, right? This is the arch we're going to rehabilitate. Imagine if this tooth is not there. Then what will there be? There will only be a full edentulous area with no tooth supporting the distal area, right? That makes this posterior area only supported by tissues, no teeth. So tissue only. And that is a distal extension case. So we must prevent tissue impingement in this area. That's what it's trying to say. Okay, so this is from our references. The characteristics of a major connector as described by the author that contributes to good health and well-being. Let's read them. Are made from an alloy compatible with oral tissue. So let's call that inert. Okay, inert, which is non-reactive to tissue, so biologically inert. Are rigid, we talked about that. Provides cross-arch stability, we talked about that. Through broad distribution of stresses. Therefore, let's add a word here, surface area. Okay, that's important. Increase in surface area. Does not interfere with and are not irritating to the tongue. So, not irritant. Do not substantially alter the natural contour of the lingual surface of the mandibular alveolar ridge of the palatal vault. So again, inert. It keeps coming back. Does not impinge on oral tissue when restoration is placed and removed or rotates in function. Impingement, same thing again. Covers no more tissue than absolutely necessary. Of course, let's add here conservation. Conservation. Okay. And does not contribute to retention or trapping food particles. By retention here, it's referring to food lodgement. Okay. And have support for other elements of the framework to minimize rotation tendency and function. So let's add here stability, which is, in other words, horizontal forces distributed well to prevent rotation. Okay, and contributes to support of the prosthesis. That's just the basic. So let's talk about some mandibular major connectors. There are lingual bars, lingual plates, sublingual bars with cingulum bar, which is a continuous bar, and cingulum bar alone, which is a continuous bar, and a labial bar. Now, these are very much bars, except for this guy here, which is a plate. A bar, just like it's referred, is more cylindrical, okay? Which means that this thickness is going to be thicker than a plate. Now, a plate is more of a broad, but a very, very fine thickness. Thick, but not as thick, right? Not as thick as a bar. And that's a plate. Therefore, this thickness, which is, if I were to draw this vertically, it would be this thickness, right? That is less. So let's talk about one at a time. Lingual bar. Lingual bar is the most commonly used in the mandible. It's located below the gingival margin. And we'll take a look at the diagram, so don't worry. The description says it's located below the gingival margin. How much below? It requires at least 7 to 8 millimeter space between the floor of the mouth and the gingival margin. So now all of a sudden, a gingival margin is very, very important. Imagine if this is a palatal side and that's the cingulum, and this is the gingival margin, right? Now, from this area to the floor of the mouth, it says we need 7 to 8 millimeters. Then we can use a lingual bar because of its own diameter, right? Its own thickness is around 4 millimeters, for example. Therefore, you need another 4 millimeters so that the floor of the mouth does not impinge. But lingual plate, it's a broader bar covering the lingual surface of the teeth, and it's used when there is insufficient space for lingual bar. So essentially what that means is whenever there is less than 7 millimeters of space from the gingival margin to the floor of the mouth, that's when you use a plate. Simple. So sublingual bar, what is that? Well, it's placed lower than a lingual bar to accommodate a high floor of the mouth. What's that trying to say is that whenever there is a requirement for an alternate with a lingual bar placement, that's when sublingual bar comes. And its cross-section. Its cross-section is different. And we'll take a look at the diagrams and it'll make a lot of sense with the diagrams. So then the lingual bar with the cingulum bar. Now what's that? Well, a combination for increased rigidity. It's a lingual bar that kind of goes up. So if it's a lingual bar here, it kind of goes up and covers the cingulum as well. Okay. It's used when there's anterior teeth that need support. Now imagine if there is loss of periodontal support and the anterior teeth are prone to mobility, right? In that case, we need a cingulum support. It's like a back support. It's bracing its spinal cord, right? It's just holding it from the back so you don't fall. And then of course the cingulum bar alone, it's a bar resting on the cingula of the anterior teeth. It's used when there's anterior support absolutely necessary, but we cannot have a lot of bulk because, well, the floor of the mouth is less than 7 to 8 millimeters away from the gingival margin. Now, the labial bar is used when severe lingual inclination of the teeth prevents the use of lingual connector. Imagine if the mandibular teeth are lingually tilted. Where are we going to put the lingual bar? Therefore, we're going to put the labial bar. It's selected when lingual connectors are contraindicated. Now, lingual connectors are contraindicated when there are lingually tilted centrals. So let's break each of them down. This is a lingual bar. Well, take a look. It's on the lingual surface of the cast, right? This is the floor of the mouth, below the tongue, on the ventral area of the tongue. This is the gingival margin, right? And we're going to take, for example, the lowest gingival margin for reference. And this dimension must be 7 to 8 millimeters in height. That's the requirement. So the definition. And it'll make your notes easy as well, guys. We've made these notes very simple to comprehend the concept. So lingual bar. It's a mandibular major connector with a half pear shape in cross section. So essentially, if you were to cut this in half, what would you see? You'd see a flat surface towards the the mucosa here, right? And then it would be a half pear. So what does a pear look like? Something like that. And that's what the bar would look like. It's positioned above the moving tissue, but far below the gingival tissue as possible. Typically made up of reinforced 6-gauge material for rigidity and support. Well, all we need to know is just the rigidity and support. Design considerations. Like we said, it's got to have a tapered superior border to avoid sharp margin. So imagine if this is where the tooth is, which is the central, right? And that's a little bit higher actually. So if I were to draw this again, for example, it would be central. This is the gingival margin, floor of the mouth, right? Floor of the mouth. Right? And right here is where the lingual bar is. So the tongue would be here, right? So essentially you want it to kind of parallel the tongue so that there is no sharp margins. And it must be located at least 4 millimeters below the gingival margin, and 7 to 8 millimeters space must be present. Inferior border should be rounded, this one here, after casting to prevent tissue impingement. So essentially what do we find here? We found that it must be located 4 millimeters below gingival margin. A total of 8 millimeters is required until the floor of the mouth, which means that the thickness of this bar is 4 millimeters. Because it came down around 2 millimeters and this is around 2 millimeters. This total is equal to 8 millimeters. And that's the goal. And that's the rule. That's the Bible of lingual bars. Now, location factors. Should not impinge on the floor of the mouth. Simple. Is positioned as inferiorly as possible. And it must prevent food entrapment and gingival impingement. So essentially, if I were to ask you guys here, do you see this little crevice? That's where food will get impacted. Therefore, that is invalid. The design must actually just be approximately like what's in the black. Like that. Okay? So let's move on. This is a diagram from our references. If I cut this in cross section here, this is what we'll see: half pear shaped lingual bar pattern. This is the gingival margin. This is the floor of the mouth. Total has to be 8 millimeters. Its own dimension is around 4 millimeters. Therefore, this is 2. This is 2. So this half pear dimension right here, half pear, is very smooth, right? Rounded after being cast in metal. Rounded. So if I'm being more precise and to make more sense, in this diagram, you notice that from the gingival margin, it's asking it to be a 4 millimeter dimension to the superior border of the lingual bar. And then, of course, the floor of the mouth needs to be 8, right? Well, that means this guy right here has to compensate for 1 millimeter, which means from the gingival margin to the superior border of the lingual bar connector, then from the inferior border of the lingual bar connector to the floor of the mouth. This is the dimension we need to cover for it to be 8 millimeters. Therefore, if this needs to be 4 millimeters, and of course we need a total of 8, right? So all we have left from here to here is now 4 millimeters. Therefore, this dimension can then be reduced to just 3 millimeters. That leaves this as 1 millimeter. Therefore, if you add it up, 1 plus 3 plus 4 is equal to 8. Okay, that's also a good calculation. Now, what are the indications? Well, whenever sufficient lingual vestibular space is available, 7 to 8 millimeters, between the floor of the mouth and the gingival margin, it is indicated. When minimal tissue coverage is desired to maintain oral hygiene. Minimal tissue coverage is desired to maintain oral hygiene. When no severe lingual inclination, so if teeth are normally inclined. When no large mandibular tori present. When is it contraindicated? It's contraindicated when there's a high floor of the mouth, less than 7 millimeters. Then, of course, we just use a lingual plate. Simple. Severe lingual inclination of remaining teeth, that's when we use labial bar. Simple. Prominent lingual tori that interfere with the placement, and of course that's when we use labial bar. In addition, if additional indirect retention is required, then a lingual plate may be a better choice because, indirectly speaking, labial plates that cover the back of the teeth provide indirect retention of the actual denture base. What are some advantages? Advantages are minimal soft tissue coverage. It's better hygiene. It's very nice. It's 4 millimeters only, right? More comfortable for patients compared to broader connectors. Okay, well, it's less plaque retentive for sure than lingual plate because it's rounded and things slide off of it. And it does not interfere with normal tongue movement. But some disadvantages, if we may, it lacks additional indirect retention. Plates are better at indirect retention. So important point here. It requires precise vertical positioning to avoid tissue impingement, 7 to 8 millimeters. I feel like we're never going to forget this number. May compromise rigidity if insufficient bulk, and of course incorrect shape is used, and the shape has to be half pair. Bulk is important. So let's talk about the bulk. Linguoplate. Well, today's lecture, and for all of the following components, we'll talk about definition, design, and location a lot in uniformity. So it's easy for you guys to make your notes. Well, in definition, it's a major connector, right? It's extending from, such as a lingual bar superiorly to cover the cingula of anterior teeth. So look over here. It kind of starts as a lingual bar, kind of does, but then it thins out. But as it thins out, it covers the cingula of the anterior teeth, lower, of course. The designed is for maximal rigidity and minimum bulk, right? We need to reduce the bulk, but we need to increase the rigidity. So what are we going to do? In order to increase patient comfort, we're going to thin it out, but we're going to increase the surface area coverage. This will take care of the rigidity, but it will reduce the bulk, right? And that gives you patient comfort. Superior border should be scalloped. Scalloped, in other words, is like how curtains are, to follow the contour of the lingual surface of the teeth. Design considerations should be thin, while ensuring rigidity. Contours closely to the lingual surface, right? We said scalloped. Superior borders should not extend beyond the middle third of the teeth. Remember, cingula, that's all we need, cingula. We do not need anything more than that. It should fill interproximal spaces, otherwise there would be food entrapments, right? And then, of course, it's used when lingual bar cannot be placed. When can it not be placed? When there's less than 7 millimeters of space from gingival margin to the floor of the mouth. It helps stabilize periodontally weak teeth. Yes, it does, because there's a lot of coverage here, right? And of course, it helps as an indirect retainer because we said it stabilizes periodontally weak teeth. So here's what it looks like. This is what a lingual plate looks like. It's got a lingual bar-like structure, but then extends up on the cingulum. Right? It's rounded still, so it's very nice. And it covers about half the tooth surface. So, indications. And of course, we said we will keep the format as is, guys. So, indications. High lingual frenum, or insufficient space for a lingual bar. We went through that. Flat residual ridges, where teeth must be assisted in denture stability. So, periodontally weak teeth. Future loss of anterior teeth is anticipated, so it allows for easy tooth additions because it's covering the cingula. So all you got to do is add a tooth there. And then, of course, the contraindications, which are severe lingual inclination, and that's where we use the bar. So things are now starting to repeat themselves, right? Whenever there's an unaesthetic appearance, when there's spacing between anterior teeth and now the metal is showing, then when there's unnecessary bulk, when a lingual bar is feasible, then why create so much tooth preparation, right? You have to create tooth preparation. You can't just put it on the cingulum. The cingulum have to be ready to receive them too. So that's an issue. Advantage is that there's, of course, greater stability than a lingual bar. It resists horizontal rotational movements because it has an indirect retainer, plus it is a stabilizer. So it provides stability. It aids in splinting periodontally weak teeth and can be used when future anterior teeth are lost. Now, disadvantages. Covers more tooth surface, which means higher plaque retention risk. Possible tooth interference if it's sharp, right? If it's not properly designed. Metal visibility between anterior teeth if there's spaces. So this is what it looks like when it is in the form of an interrupted lingual plate. Interrupted lingual plate is used for when there's interproximal spaces. For example, as shown here, there's interproximal spaces. So sometimes a dentist is faced with a clinical situation wherein a lingual plate is indicated as a major connector of choice through the anterior teeth that are quite spaced out, and the patient strenuously objects to having any metal show. Okay, so lingual plate can be constructed so that the metal will not show any, will not be shown through the spaces as shown in the diagram. The rigidity of the major connector is not greatly altered. It's still there. It's pretty rigid. The bar starts down here and it goes up as a plate onto the cingulum. However, such a design may be as much of a food trap. Imagine how much food trap can occur here, 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 right? Okay, and let's talk about the sublingual bar really quickly. Not the most used, but let's talk about it, right? This is the example. Look how low it is from the gingival margin, and look how close it is to the floor of the mouth, right? As well as in this diagram here. This distance is way too much as compared to this distance. Well, the definition, it's a modification of a lingual bar, okay? It's positioned inferiorly and posteriorly than the usual lingual bar location. It lies over and parallels the anterior floor of the mouth. It's that low. Well, when do we use it? What's the indication? Whenever there's a high floor of the mouth, right? It's a really, really high floor of the mouth. It prevents the standard lingual bar. We want to keep the gingival margins free, okay? When the gingival margins need to be free. The presence of anterior lingual undercut that requires excessive block out if there is a lingual undercut. So if I erase this here and show you that this kind of goes like this, and that undercut needs to be blocked out. Contraindications, interfering lingual tori, preventing the placement. Very simple. Any interference, high lingual frenum, attachment could interfere. Any interference. Active tongue movement that, and the shallow floor of the mouth, can cause discomfort. Again, interference. Not used, by the way, so don't worry about this. Labial bar, not really preferred either. Look how bulky that may look on the anterior lip support region, right? So definition, it's rarely used. It's used labially instead of lingually. Indications, when do we use it? Lingually inclined teeth, simple. Prevents a lingual connector from being placed where there's severe lingual tori that cannot be removed, and then of course surgery needs to be done and so on. When there's extreme lingual tissues, undercuts, making lingual bar or lingual plate difficult. So our primary choice is lingual bar or lingual plate. And contraindications for a labial bar, there's got to be 100, but the most important ones are, should be avoided whenever possible. So great, never use it. Anesthetic due to visibility on a labial surface. It's not aesthetic, right? It requires additional bulk for rigidity, which may contribute to discomfort. Then comes a cingulum bar, and just the cingulum bar, right? Look how open these teeth are, guys. So it's just the cingulum bar. Right off the bat, tell me how many people do you think it will have food lodgement. All of our hands are raised, right? So cingulum bar. It's all the way up on the cingulum. It's a thin metal strap located on or slightly above the cingulum of the anterior teeth and can be combined with a lingual bar, and that makes it a lingual plate, right? So what are some indications, right? There's lingual plate alternative. It is an alternative to the lingual plate where excessive blockout is required. So if there's a lot of undercut, a wide diastema spaces between anterior teeth, that makes a lingual plate an aesthetic, right? Not aesthetic. Used when some indirect retention is needed but less bulk is desired. So whenever indirect retention takes precedence, we use this indirect retainer. And again, don't mix this with the actual indirect retainer that we will talk about later in a separate lecture, because that has to do with a rest, okay? And it's where we place a rest that's important. So that's different. This is just the act of indirectly retaining the denture. Contraindications: severely tilted anterior teeth preventing proper adaptation. Anterior tilt seems to be a contraindication for a lot of major connectors. Metal visibility between anterior teeth can be an aesthetic, and of course less rigid than lingual plate, requiring additional support. It's less rigid. So then, whenever we're designing a mandibular major connector, what are some steps that we should follow? Well, step one, outline the basal seat area, so where the denture base will seat on the actual diagnostic cast. Define the areas where the denture base will be. Step two, outline the inferior border of the major connector. That's very important because it tells us how far it is from the floor of the mouth. It should be placed 4 millimeters below the gingival margin or as inferior as possible without interfering with the floor of the mouth, right? So that's very important, that it needs to be placed lower. So in this design, for example, if this is our tooth, that is such a terrible tooth, apologies. Let me redraw the tooth. There we go. Now that's a tooth. And then comes our gingiva, and of course this here will be the floor of the mouth. If the requirement is that from here, from the free gingival margin to the floor of the mouth, roughly 7 to 8 millimeters is required. Okay? In this case, if we're making a lingual bar, then we have made sure the lower border in this case is 4 millimeters away. That makes we have 4 millimeters remaining, minimum, right? Minimum, out of which 3 millimeters could be the actual bar. 3 millimeters could be the actual bar. So that's why we do the lower first. Step 3, outline the superior border of the major connector. And then, of course, we just outline the superior border. It should be placed in position that avoids gingival impingement and still ensures rigidity. By that, it means it needs to be 3 to 4 millimeters wide. Step 4, connect the basal seat area to the inferior superior border and add a minor connector. Minor connector will retain the acrylic denture base material to this major connector. It ensures the stability and optimal support. Now this I will show at the very end in a diagram that we will discuss. So here are the steps. This is from the reference. You can pause here and take a look at what happens. First of all, they have denture base identified, where the teeth will go, where there's edentulous. Then they went ahead and made a lower border. Then they went ahead and made the upper border. Then they went ahead and created minor connectors, which are grid works, right? Where the rest will go and where the indirect retainer here will go. Now, of course, these are new. But once we do these lectures one after another, everything will add up in the end. Now let's talk about the upper. Upper has a lot of variation, right? There is a strap. There is a U-shaped bar, or a palatal connector, then there's an actual bar, and there's a set of bars. Well, let's take a look how that's different. Well, a single palatal bar, combination of anterior and posterior palatal strap, apologies, I said bar here, but this is a strap, okay? Strap, Palatal plate type connector. It's a plate, a U-shaped palatal connector, and a single palatal bar and anterior posterior palatal bars. So lots of like 3 things in here. There's a plate, full coverage. Then there's a strap. That's like the Linguoplate in mandible, right? Then there's bars. So 3 types. So let's dive deeper. A single palatal strap is broad. It's a thin strap, possibly 1 millimeter wide, mainly for bilateral tooth-supported prosthesis. So here's an opportunity for you guys to go and check out the RPD introduction, because in it we talked about what is tooth-supported, what is tissue-supported, okay? And the indications are ideal for small edentulous areas because it's thin. It needs to support less teeth. If you need more teeth, then either you're going to need 2 straps or you're going to need a larger surface area covered, right? So what is a combination anterior posterior palatal strap? There's 2 straps with a rigid frame-like structure used for cases requiring additional support, additional rigidity. Palatal plate, it covers a large surface area of the hard palate for maximum stability, recommended for long span edentulous areas, and of course the U-shaped palatal connector. It's used when palatal torus is present, right? So imagine you're doing, so this is the maxilla and you're doing a U-shape. Why would you do a U-shape? Well, because there's a palatal torus there. But then of course it lacks rigidity. So selected when torus prevents full palatal coverage. Otherwise, full palatal coverage. They also have their disadvantages, so we'll take a look at that in a second as well. Then comes single palatal bar. It's a narrow, less favorable option due to limited rigidity. Used minimum in small edentulous areas, and of course there's 2 narrow bars with joint to form a slightly more rigid, best for cases with maximum rigidity. But bars for maxilla, let's not go for it, right? Let's try and avoid these in clinical scenarios as much as possible. Why, you ask? Because bars are thicker than plates and straps. Imagine a bar on your palate, and now close your eyes and run your tongue on the palate. If you feel something sticking out, your tongue will automatically go to it regularly. Therefore, it is prone to injury to the tongue. So let's start with the first one, single palatal strap. Like we said, definition, design, and some guidelines. So definition, it's a broad single palatal strap, maxillary major connector, used for rigidity without excessive bulk. There's no interference with the tongue. Look how nice and flat this is. This is a cross section, by the way. This is a cross section. Look how flat this is. Look how skinny this is, right? 22 gauge matte plastic pattern for optimal strength. It basically just gives, by plastic, it's not really material plastic. What it's trying to say is that it's not a plastic. It's plastic where it kind of adapts to the tissues, that type of plastic. Design aspects. It should be broad, covers large palatal area for rigidity. So essentially, there is a dimension of this. There is a dimension between the gingival margin anteriorly and the palatal surface, anterior surface, and of course there is dimension of the actual thickness, right? We'll take a look at the dimensions in a second. Well, it should avoid excessive bulk and discomfort, ideally positioned to prevent any interference with the tongue. Midsection should be slightly elevated to enhance rigidity without altering palatal contours. So just slightly in this section where I'm drawing the dot, slightly elevated. Precautions. Should not be used for distal extension cases because posteriorly extending edentulous spaces, if there was no tooth here, where would this strap go? It can't go anywhere. Therefore, in that case, we would need a U shape, right? But we'll take a look at that in a second. If it's placed anteriorly, excessive bulk can cause speech interference and patient's palatal discomfort. So, indications. Let's talk about some indications of single palatal straps. Short span bilateral, short span. Unilateral tooth supported, that's a class 3. Right? With cross arch attachment, class 3 mod 1. So we're just trying to jog our brains back to the previous lecture as well. Should be confined within supporting rest for maximum efficiency. Contraindications. Distal extension cannot be used. Therefore, anything that is tissue supported, we cannot use it. Cases where wider palatal coverage is required, that's where we use the plate or U-shape. Situations where excessive bulk could interfere. Interference has always been a contraindication, guys. Advantages. Strong, rigid, large surface area, minimum interference with tongue function, more patient comfort compared to bulkier connectors. Disadvantage, not suitable for distal extension as usual. There's torque, there's leverage issues, speech discomfort if it's too anteriorly, and requires precise design to prevent bulk. Anterior and posterior palatal strap. So it's 2 times palatal strap, right? The design is that it's rigid palatal major connector. It consists of an anterior and a posterior, both straps that are joined together by a longitudinal component. And we'll take a look at that in the design there. It forms a square or a rectangular frame. As you can imagine, anterior and posterior with a longitudinal component, it forms a square, right? Which enhances rigidity and prevents flexure. So very rigid. It's a 4-corner frame used in various maxillary partial dentures, except in inoperable maxillary tori. What if there's a torus here? Then we can't use this. This has to go, and all of a sudden, this now looks like a U shape. Okay? Extending posterior to the soft palate, cannot use it. Design aspect. Anterior strap must be positioned as far posteriorly as possible to avoid rugae coverage and tongue interference. And that is where we're talking about the minimum dimension from anterior teeth that protects rugae. I want you guys to keep a number in mind, 10 millimeters. That's it, 10 millimeters, okay? Posterior strap must be flat, at least 8 millimeters wide, located anteriorly on the hard palate, located entirely on the hard palate, I apologize. The straps are connected by longitudinal elements, that's these ones here. Right, forming a rectangular frame enhances rigidity and can be modified to encircle maxillary tori without losing rigidity. Precautions that need to be taken. Posterior strap should not extend beyond the junction of the hard and the soft palate, so vibrating lines. It may cause discomfort because it's a movable tissue, and we must prevent movable tissues. Design must cross midline at the right angle rather than diagonally, so it cannot go like this. Okay, it can't go like that. Ensuring better tongue adaptation. If anterior teeth are replacements, if they're being replaced eventually, then anterior strap may be extended anteriorly for additional support. That's just another side statement. So here it is. This is what we're talking about. I asked you guys to remember 10 millimeters, right? See how it says 6 here and it says 6 here? I want to correct that because there was a recent article that came, and this diagram is in here for a reason. Do you see how this is 6 millimeters here? I'd like you guys to consider 10 millimeters. Okay? This is just a given rule. I need to update you guys because this textbook had 6 millimeters, but I want you guys to remember 10 millimeters. Okay? And this dimension, I want you guys to remember 6 millimeters. This is okay. This one's correct. Okay. One more thing. There is a dimension that is horizontal. This dimension, I want you guys to remember 5 millimeters. Anything less than 6, 10, less than 5 needs a modification. Simple. What type of modifications? Well, think of it this way. If this is less than 10, then Ruge is being compromised partially. So what we're going to do is take this and cover singular. Okay? If, for example, this is less than 6 millimeters in height, which is easy to control, but say if it is, then we need to have a lingual plate. This is known as an apron. An apron must also cover if this dimension from one minor connector to the other minor connector is less than 5 millimeters, it needs to be covered. Simple. And this darkened area is known as an apron. Okay, so this concept I needed to update you guys on this slide. Okay, moving on. As you can see, that there is an anterior strap and there's a posterior strap, and it's away from the soft palate. There is an area for longitudinal components that's coming down, attaching and making it a square. Okay, and of course the dimensions that we talked about, that it connects to a minor connector. Indications. When is this indicated? Suitable for any Kennedy class. Amazing. However, it's used for class 2 and class 4s. And I'd like you guys to think about the implications of a tissue and tooth supported versus just a tooth supported. So wide indication, right? Ideal for maximum rigidity required, minimal palatal coverage. Now I kind of disagree with that from the textbook, right? It does cover a lot of the palatal surface. It can be adapted to maxillary tori. That's a good point. Contraindications. Contraindications is inoperable maxillary tori. Then if it goes even beyond soft palate, then we cannot use this technique. Extensive palatal defects, cannot use it. Cases where single broad palatal strap would suffice. Say, for example, short term, single palatal, right? Left to the right. Advantage is simple. High rigidity, minimum tissue coverage, reduces flexure, and more comfortable. Very simple. Disadvantages? More complex design. Lots of different types of longitudinal components and so on need to be added. Lots of dimensions that we talked about in the previous slide may not be as strong as a full palatal plate. Not suitable for patients with large tori. Palatal plate says it's all. It's a thin, broad palatal coverage of the maxillary major connectors. Covers 1/2 or more of the hard palate. For maximum support and retention, it's designed to follow patients' palatal contours, enhancing stability, and fabricates as an anatomical replica of the palate. Uniform thickness and strength. But what it takes over is sensation. Remember that, guys. Okay. Design covers large palatal surface, anteriorly or posteriorly extended, doesn't matter. Anatomic replica, thin in nature. Posterior border terminates at the vibrating lines and avoids interference with function. Precautions? Should not interfere. It should have a proper finish line. And palatal seal, not for stability, unlike complete denture. So we don't need a seal, but it just needs to be at the posterior border, maximum. And may not be suitable for patients with inoperable tori. This is what it looks like. These are two different variations, one that covers the cingulum and gives PDL support, and this where the teeth may be strong enough and it needs to cover this palatal surface, but there must be no tori. Remember that, guys. Okay. So indications when maximum palatal support is needed. Class 1, which is bilateral distal extension cases, when anterior abutments are weak and require splinting, as we saw in the second picture on the right in the previous slide, and when significant residual ridge resorption has occurred. So we need more PDL support. Contraindications, on the other hand, for any inoperable tori, when less coverage is required, such as in a short span in a class 3, tooth supported, right? And patient has a strong gag reflex because it covers up to the soft palate area at times too. Advantages: provides maximum rigidity, support, comfort due to its thinness, contour of the palate, enhances retention due to intimate contact. Everything is great. But then there's always disadvantages, right? Disadvantages are that they cover a very large area of the palate, right? It may be uncomfortable to some patients. More expensive because more materials used, right? Difficult to modify if the teeth are lost. Okay, so the U-shaped. A maxillary major connector that forms literally a U shape extending around the hard palate, not including the hard palate. It's the least desirable due to the lack of rigidity and flexes because it's a U-shaped bar, right? And it's not the most pretty. Under occlusal surfaces, it flexes. Only used when large inoperable palatal torus is unoperable and it's still certain in the anterior placement of the denture. Design. It forms a narrow U-shaped extension around the rugae area. There's bulk and rigidity for sure, but it requires it being uncomfortable to the patient. It lacks cross-arch stability. And what was the number one principle of major connector, guys? Cross-arch stability. It leads to increased flexion. It can be modified to encircle maxillary tori, of course, and precautions need to be taken because anterior border should be at least 6 millimeters away. I say 10 millimeters, as per new guidelines. If contact with teeth is unavoidable, then the connector must be supported by rests and their seats. Should not be used arbitrarily as it lacks its rigidity, right? It induces torque. And this is what it looks like, a U-shaped bar, right? If there's a torus here, great, it's a very, very good area, but it covers the rugae here. And remember, this needs to be 10 millimeters in height. This has to be 5 millimeters horizontally. This has to be 6 millimeters vertically. That rule remains the same, you guys. And if that cannot be met, we must apron it. Okay, indications as usual with the charts. Indication: large inoperable maxillary torus, preventing palatal other palatal connectors. So it's a secondary choice, not a primary choice. When multiple anterior teeth require placements, when a patient cannot tolerate posterior coverage. But we need support, so we're going to use the anterior area, such as the rugae region. Contraindications: cases requiring maximum rigidity due to its flexibility. It flexes. So we need more rigidity. We cannot use U-shape. Patients with adequate posterior support, where a more rigid design should be used. Rigidity again. Situation where bulk in the rugae area will cause discomfort. That's very common, right? So that might be a problem. And that's why we're going to go 10 millimeters, guys. Remember. Advantages: can be used in patients with large tori, allows freedom of the tongue in the palatal region, less coverage of the posterior of the palatal region. So all that's very nice. But disadvantages: rigidity can cause torque due to flexure, can provide lateral stresses on abutment teeth that hold the denture, requires excessive bulk in the rugae for rigidity purposes, and may cause interference with speech and tissue impingement under occlusal load. Single palatal bar. So now we got two bars left to talk about, right? Single palatal bar. It's a narrow bar, major connector, less than 8 millimeters in width. Anything wider is called a strap. Design aspects: centrally located between the halves of the denture. Okay, so it's right in the middle of the palate. Must have concentrated bulk, right? Otherwise there's no rigidity. It's just one little bridge, which is often lacking cross-arch stability. It's just narrow, less than 8 millimeters. It's indications that it's a short span class 3, right? So class 3 is technically a jaw like this with a tooth missing here and a tooth missing here, for example, and it just joins it. That's it. When palatal coverage needs to be minimized. Distal extension cases are contraindicated. We cannot have this in a distal extension case. It will lack support. Due to greater rigidity, it of course lacks cross-arch stabilization. Patients with high sensitive palate who cannot tolerate this bulk area just sitting there across the palate. Advantage: minimum palatal coverage use, easier to fabricate. No, that's just any advantage. I don't really believe that these are even true advantages, because the disadvantages: least logical. Due to flexibility, too thin, lacks rigidity. If too bulky, it will cause discomfort. So lacks support and cross-arch stabilization, right? It fails. Same thing with combination. In any way, it's just a combination of anterior and posterior bar, creating dual bar systems for maxillary RPDs. It's meant to enhance rigidity and cross-arch stabilization, so basically an anterior bar should be flat, placed posteriorly to avoid rugaso more than 10 millimeters. Remember that, guys. Posterior bar should be flat, at least 8 millimeters wide, placed entirely on the hard palate, still prone to bulk. Right? Indications are when anterior posterior stabilization is required. Now, where cases have a single strap that is insufficient, but full palatal coverage is unnecessary, yeah, I mean, to me, that's a made-up indication, because look at the contraindication. Patients with large maxillary tori, like any other, situations where strap and plate would be better. That's 90% of the cases. Advantages: better rigidity than a single palatal bar, of course. Minimal palatal coverage compared to full plates, of course. But look at the disadvantages: too bulky, speech interference, not rigid, may interfere with tongue, and so on. So here are the maxillary major connectors. This is a single palatal strap. This is anterior posterior palatal strap. This is a palatal plate. This is the U-shaped. This is a single palatal bar, and this is anterior posterior palatal bar. So then what are the design components, the steps for design? Apologies for this J. This shouldn't be there. Okay, step 1. Outline primary bearing area, so denture base areas. Identify edentulous ridges, technically, just the same as mandibular. Step 2. Outline non-bearing areas, something we need to avoid, such as relieving areas, right? Gingival tissues within 5 to 6 millimeters of remaining teeth. So any less than 5 or 6 millimeter of remaining teeth. Avoid hard and soft tissue structures, such as mid-palatal raphe, any tori, posterior vibrating area, the lines in the back, right? Soft palate. Number 3, outline connector areas. Remaining palatal areas we must define with a major connector. Ensure it does not interfere with function, maintains rigidity. Rigidity is important because it's cross-arch stabilization. Step 4, select the actual connector on the basis of comfort, rigidity, denture base locations, and indirect retention that is needed. Step 5, unification of all these components. Ensure that the denture base, the major connector, and everything that joins is rigid, and it covers minimal palatal surface for conservation that we wrote on the other slide. And this is just a diagrammatic representation of the same concept that we just talked about. You can stop and take a note here as well. Then comes a little bit of short notes, right? We'll talk about a few short notes here. Number 1 being beading. So if you notice, there's a little bit of a 3-dimensional structure around the borders of the actual major connectors. So what's beading? Beading is a grooving or an elevation of the borders of a maxillary major connector in the actual cast stone. It is done to ensure proper adaptation, tissue contact, and of course retention of the actual framework. We must either indent or elevate it. Purpose: creates a positive seal. Very simple. At the periphery of the major connector, prevents food entrapments when it's sealed well, increases rigidity, helps in compensation of metal shrinkage. Now, technique. How do you do it? How do you actually bead a cast? Well, 0.5 millimeter deep wide groove is carved along the borders of the actual designed major connector. This creates a raised edge of the metal framework. Fair enough. Ensuring a close adaptation of the palatal tissue. The beaded margin should be smoothly tapered to avoid any discomfort. And this step is very important. And this is what it looks like. You can actually tell that the indentation has been made, right? And then of course this is the elevation of it, right? The wax pattern elevation following the bead lines. It gives the metal framework an idea of where to be. And this is just another example of the cast that is formed. You can notice how there is an actual elevation of the metal framework that actually goes into the cast like that. Now imagine that on a tissue surface, right? It adapts really well. So let's talk about minor connectors. The concept is that there's small metal components that links the major connector with other components of the RPD. It provides stability, distribution of forces, and retention. Key principles, same thing, rigid, minimum bulk to avoid discomfort, and avoid food entrapment. So definition-wise, right, from the glossary of prosthodontics, it's a removable partial denture prosthesis part that joins major connector with other parts, such as direct retainers, indirect retainers, rest, and denture bases. These are individual lectures on their own. But on the diagram on the right here, you'd notice that there's a rest, there's a clasp assembly, there's a proximal plate, there's a denture base component, also serves as a minor connector, by the way. But this vertical component, remember at the initial part of this lecture, we talked about the word vertical. Vertical is very important. This is a minor connector. It contacts everything. It contacts the rest, it contacts the guide planes, the proximal plates, it contacts the denture base, everything from the major connector. And that's why it's called a minor connector, guys. So what's the primary function? It unites denture components. Number one, done. Transfers functional forces from occlusion to supporting structures. Its job is to distribute forces. Prevents rotational movements, so rigidity, stability. Distributes stress evenly across the prosthesis, so stress distribution. Aids in indirect retention, so it of course helps with the, connects the rest to the major connector. It indirectly retains the denture. Then the types of major connectors. Or minor connectors, apologies. Those connecting direct retainers and indirect retainers to the major connectors. Then there's those connecting the denture base to the major connector. Then the ones that approach as arm type of the bar type direct retainers, so clasp assembly type. And then of course the lattice work to the mesh work minor connectors that retain the acrylic. So all the ones we talked about in the previous photograph. So in this photograph, for example, so this is a major connector. Done, right? Perfect, beautiful. Then this is a rest, this is a proximal guide plane, this is a clasp assembly. Done, okay. Well, here is the minor connector. Minor connector, minor connector, minor connector. Okay. This is a minor connector, minor connector, minor connector. This is also a minor connector. So many minor connectors, right? Its placement is very important. It must always be placed at right angles to the major connector. Must not impinge on soft tissues as usual. Positioned adequate relief as usual, and rest should be connected via minor connectors. So essentially, right here, if I erase this, we can tell major connector, minor connector, 90 degree. Major connector, minor connector, 90 degree. Right, that's what we need to make sure. So then there's something called as finish lines. Finish lines are very, very exciting. Okay, they're not that simple to understand, but they're very simple things. Finish lines is a junction where the metal meets the acrylic. Simple. So it provides a smooth transition between these two materials, ensuring proper adaptation. There will be a place when 100% of the metal meets 100% of the acrylic that will eventually be filled here. Do you see how 3D this looks as compared to this? That's intentional. It's actually slightly elevated. That junction is slightly elevated, and it's located 2 millimeters medial from the imaginary line that would contact the lingual surface of the missing teeth. The finish line on the right is far too outwards to the midline. The natural contours of the palate will be altered. So let me erase this and show you. It says the finish line on the right side is too far towards the midline, all the way down here. Right? What it needs is to actually have a finish line here. Okay? Ideal placement, finish line is too far medially, then what happens? The palatal contour will alter, like this guy here, where there's excessive bulk at the junction. Right here, there will be excessive bulk right now, because it's too medial. If it's too buccally placed, like if for example, all of this is placed here, Imagine if it's too buccally placed. It's difficult to contour the acrylic resin on the lingual surface, and then there's just metal here, which is pretty odd, right? So ideal location is to preserve natural palatal shape. So when we replace teeth, say I want the tooth here, I want the tooth here, it just needs to end in this section here. That could be the finish line. Simple. Okay, guys? So the junction with the major connector, the finish line angle at the junction of the major connector should not be more than 90 degrees. Means it needs to be a butt joint. That's all it means. That whenever you have a major connector and then there is a finish line, right? So this is a lower. Lower has a major connector and a finish line right here. This is a major connector, and this is where the acrylic will kind of go around this denture base area, retention area, and this is where it would meet, right here. All it's saying is that it should not be more than 90 degrees from the major connector. Very, very basic. Medial extent of the minor connector is influenced by the lateral extent of the major connector. That's literally this: lateral of major, medial of minor. Okay. Junction of the minor connector and direct retainers. Well, the junction between the minor connectors and the bar type retainers, which is like a clasp assembly, it should be 90 degrees butt type joint. So anywhere, all we need to know, finish lines are supposed to be 90 or less. Right? It should not exceed more than 90 degrees. Otherwise, what would happen? It would flex and it would break. Like, for example, imagine the major connector came like this and this was the finish line. Amount of area that is here is unsupported. If there is force here, it will break. Right? So butt joint is very important. These joints should follow guidelines for base, contour, clasp, length, and ensure proper fit. Okay, so then the type of finish lines, this is just a short note for our references: external, internal. External is the tissue side of the major connector. On the tissue side, intaglio surface. It's the visible junction between metal and acrylic base. It can actually tell. If you turn it upside down, you can tell where metal ends and acrylic begins. The purpose is to ensure smooth transition, right? Prevents spoon entrapment, enhances aesthetics, and so on. Key is that must be well defined for seamless integration. Should be positioned to avoid bulkiness and irritation. Very simply, a kind of smooth transition. Internal, however, intaglio surface of the major connector contacts the area between the metal and the denture base. Right? It provides the mechanical retention of the acrylic resin, where it compensates for metal and shrinkage during casting and contributes to structural strength. This is, we'll show in the picture in the next slide, this is where the acrylic that interwovens into the denture base and attaches to the actual denture base. It should be well adapted to ensure strong metallic acrylic bond. Helps in stress distribution. So internal finish line is more important, and of course 90-degree butt joint finish line is necessary. It's the junction between minor connector and acrylic denture bases. Common at bar type direct retainer. This is a clasp assembly. We will discuss this more in detail in another lecture. The purpose of the butt joint is basically creates a strong, definite connection, ensures stress distribution and stability. It should follow proper base contour guidelines, needs accurate positioning to maintain class. So positioning is important. So here's a diagram. This is a frontal cross sections through the lingual finish line of a palatal major connector. The right side image through the full cast metal base connector, major connector. Left side image is through the resin denture base. In both situations, the location of the finish line is minimizing the bulk of the resin attaching to the artificial teeth. Palatal contours are restored, enhancing speech and contributing a natural feeling of the patient. So think of it this way here, guys. This right here is the buccal surface, right? This right here is where the metal interplays into the structure itself. Look how at this point right here, there's 100% of metal, 100% of plastic, which is acrylic, right? Whereas on this surface, it plays a role internally. It takes its course into the metal on the buccal surface itself. So that right side image is through a full cast metal base major connector, and the left side image is just through a resin denture base. But the finish line is must at butt joint. That's the purpose of this diagram right here. That's the takeaway for home. So, finish lines. Where should a finish line be? This is a denture flipped upside down, exposing the tooth and tissue surface, known as intaglio. Intaglio. Okay, actually it's called intaglio, but I just say taglio because I don't want to waste the G. It's nice. Okay, so 100% of acrylic meeting 100% of the metal. That's a finish line. What kind? Internal finish line. So in this case, if I were to draw, say, a rest here, so remember, this is a distal extension case, right? Distal extension case is something that needs stress breaking. Stress breaking is going, and okay, of course, we'll take a look at this in the class assembly. It's very exciting. I'm very excited for the lecture, guys. But what it needs is a rest that is on the other side. It needs a denture lattice right here, not a mesh, lattice, because it's a longidentulous space, where it comes off of as a proximal plate. Ooh, that's a terrible plate. Proximal plate kind of comes off like this. And then a bar type I bar comes out of like that. Actually comes out of the denture base, but okay. And then there's a minor connector that connects all of this. Minor connector that connects all of it. This is just an example, of course. Right, and it does the same thing here. Now, the finish line where the acrylic would start would be in this blue section. Acrylic, 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 acrylic. It kind of comes down to the vestibule, acrylic, acrylic, comes down to the vestibule, acrylic, acrylic, acrylic. And all of a sudden, we notice there's acrylic here, and there's acrylic here that begins as a lingual flange, right? So essentially, this is the external finish line. And when you turn it upside down and this pops out, this is the internal finish line. Simple. Let me erase it so you guys can see it. Fair enough? Okay. So let's point out the finish lines. This thick area, 100% of the metal, 100% of the acrylic. This thick area, 100% metal, 100% acrylic. This thick area, 100% metal, 100% acrylic. These are external finish lines, okay? So then lastly, let's just talk about tissue stops. Remember, tissue stops are an integral component of the minor connectors. It is type of a minor connector. It helps and play a role in retention of acrylic resin denture bases. Retention of acrylic resin. Play a key role in stabilizing the framework during both impression making and processing stage. It just keeps everything away from distortion and during acrylic resin processing procedure. So whenever, basically, all this is trying to say is when there's a metal frame ready, okay, metal framework ready, and it needs to be placed and replaced by acrylic, in that stage, this framework needs to remain stable somehow on tissue as well as the cast. And that's where tissue stops come. The primary function is to stabilize the framework. Done. Problem solved. This is a terrible star, by the way. I don't know what's happened to my diagrams today. During impression making of the acrylic processing. It prevents the framework distortion during resin polymerization, like this process that we talked here. It engages the buccal and the lingual slopes of the residual ridge to kind of provide more stability on both sides. So let's take a look. There's a buccal and the lingual slope of the residual ridge. There's a distal terminal abutment, and then it's at the junction of the minor connector and the acrylic denture base. There are three different types of tissue stops. Let's talk about each of them. Buccal and lingual slopes of the residual ridge. It ensures stability, metal framework, during transfer and processing, right? Prevents distortion of the framework. Great. Key consideration, maintain proper positioning and avoid excessive pressure on the ridge. That's all we need. We don't want any more pressure on the ridge. It's irritating. Distal to the Terminal abutment functions as a continuation of the minor connector that contacts in the guiding plane. Now I know it's kind of just wordy and no diagrams. That's the next slide. It establishes a definitive finishing index for the acrylic resin. That's where it stops. No more denture base acrylic after that, basically. Helps maintain accurate seating because it's all the way in the distal extension, and it prevents the shifting of the denture base posteriorly after processing, right? At the junction of the minor connector and denture base, provides reference stop, alters the cast impression procedures. Altered cast impression. Altered cast impression is a whole different concept. How to take two different impressions of the same type of RPD. And can be augmented with autopolymerizing resin for adaptation. So this we'll talk about separately. Okay? It's a whole different concept. So here it is, tissue stops. Where are they? Distal tissue stop, distal tissue stop, distal tissue stop, right? This is where it stops. There's a tissue stop right there. After that, there is no need to extend the acrylic component, right? It shows tissue contact posterior to minor connector with planned relief, right? Basically, it's seated where posterior relief wax is needed at the distal residual ridge, and tissue stop will be waxed. Like in this case, it's going to be waxed. Then the wax tissue is placed on the distal to relieve the area after the casting. This will result in an actual metal tag that comes out. And then of course the acrylic will flow in it. So it kind of allows, for example, if you look closely, there's a little bit of a gap right here. So it kind of lifts this frame from the stone, and that's where the acrylic will flow and create a nice base. So how to draw a major and a minor connector on a cast? Remember, always survey first, and survey is a separate lecture as well. So first of all, let's identify what this is. This is a class 2 mod 2, right? Class 2 unilateral posterior, and then 2 mods. Okay. Essentially, this is a distal extension case. Okay. So what we need, and I'll draw the other things in black here. First of all, we need to identify that it's the upper. So let's identify the edentulous and then the dentate areas according to the steps. So this is going to be our edentulous area. Right? Perfect. And then of course it's a long area. So instead of it being a mesh work, we're going to do a grid work. A lattice work. And then of course the denture base comes out just like this, 45 degrees. And same thing on the other side, mesh work, denture base, 45 degrees, 45 degrees. You know what I'm very excited about, guys? I'm excited that once you guys finish all of these RPD lecture series, it's going to be so exciting because everything will fall into place. How we made this design, why we came with that concept and everything. I'm just so excited. Anyways, I'm running ahead of myself. This area right here is tooth supported on both sides. Therefore, what we can do is provide a rest here, and a clasp here, clasp here, clasp here, and clasp here. Right? Over here, this area is distal extension. Therefore, we need a remote rest, which is opposite side of the edentulous space, stress breaker, right? A proximal plate that comes off like that, vertically down, and an eye bar that comes off like this. Right, now everything is ready except for the major connector. So we need to connect this section, of course a minor connector from this section, a minor connector from this rest, and from this section over here, which connects to this section right here. What do you think we'll use? Well, it looks like we will use something that connects everything here. There we go. And that's a U shape, right? So this is just a rough diagram, right? What we're trying to do is we're trying to determine edentulous spaces, dentate spaces, and then we're trying to bring down minor connectors by maintaining our rule of thumb for the dimension horizontally, which is 5 millimeters. This will be 10 millimeters. Posterior dimension, which is going to be 6 millimeters, right? So this is 5, this is 10, this is 6. And finally, we join in. So if I were to do the same on this diagram here for the lower, we would have this is, first of all, this is a class 2. No mods. Okay. So edentulous spot. Very, very basic. We will draw a denture base coming out like that and 45 degrees other way. And it stops here. And then a metal comes out here, right? And stops. This is normal, right, in this case. But remember, there's nothing that needs a cross-arch stabilization here. So what we'll do is we will only clasp this area. Just this area, we will clasp. So it will end up coming around like this, and we will minor connector, rest, clasp and clasp. Very simple, right? Okay, essentially what I'm trying to get at here is, in this case, where would the metal end? So it would be like this, and it joins, right? So if you think about it, the acrylic is here for sure, but it goes within the grid work and it touches the metal component on this side. And over here is where the metal 100% begins. So this junction is the finish line. That was my purpose here. And in this case, the major connector that we would use is a lingual plate or a bar, depending on the vertical dimension of floor of the mouth from gingival margin, either 7 to 8 millimeters or less. And our references are usual, McCracken's RPD and Rangarajan's textbook of prosthodontics. For any questions, please contact us with the links in the description box, and hope you had fun and look forward for more RPD content. Thank you. Have a great